Hi everybody, my name is Daniel Lay. I'm going to be narrating our group's project and presentation on the clinical nurse specialist role. Here are the contributing members of our group for the following presentation. And the CNS role evolved from specialty training and the need for additional training in areas of specialty. The term specialist can be traced back to the turn of the 20th century. Hospitals offered postgraduate courses and a number of specialty areas. In 1954, the first psychiatric nursing program at Rutgers was established and considered to be the first CNS education program. In the 60s, the CNS role reformed again following the Nursing Training Act of 1964, in which a number of CNS master's programs were created. In the 1970s, the ANA officially recognized the CNS role as an expert practitioner and change agent. The NACNS has established 3 distinct spheres in which the CNS practices. This includes the patient-client sphere, nurse and nurse practice sphere, and organization and system sphere. The CNS is first and foremost a clinical expert who provides direct patient care with complex healthcare problems. Additionally, the CNS role includes consultation, education, and collaboration for research and implementation of evidence-based practice. When looking at the CNS and the nurse practitioner role, the differences are largely dependent upon individual attributes, the context of the practice setting, and characteristics of the patient population. Unlike other APRNs, whose primary role is to deliver direct patient care, the multifaceted CNS delivers direct patient care specifically to complex and vulnerable populations. Additionally, they educate and support nursing staff, provide leadership, leading to program development, and facilitating change and innovation in the healthcare system. But overall, the biggest point of emphasis is delivering direct patient care to complex and vulnerable populations is really what sets this role apart. To become a CNS, you need a BSN degree and RN licensure, from which you can apply to an MSN or DNP program with a CNS tract. Within that curriculum, you can choose an area of emphasis. For example, if you want to work with palliative care patients, you're going to be completing competencies and curricular preparation on the adult population in palliative care specialty. There are also other areas, including adult gerontology CNS, pediatric CNS, and neonatal CNS. Candidates for certification must complete an exam based on competency through the ANCC or the AACN. Because the role is so multifaceted and there's such a variety of settings, work settings are numerous, including long-term care, hospital, community public, home health, pediatric critical, and healthcare administration. Additionally, there are also other programs that prepare CNSs to be educators, or evidence-based practice emphasis in which research is the biggest part of your position. The scope of practice for the CNS role is largely state-specific. CNSs can now practice independently in 28 states and prescribe independently in 19. There's a number of different variations of what's allowed. For example, full scope of practice states have no requirement for a written collaborative agreement and no supervision required from an overseeing physician. Collaboration required states have a written agreement specifying a scope of practice and medical acts allowed with or without general supervision by an overseeing physician, such as an MD, DO, DDS, etc. In areas where there's limited scope of practices, CNSs have no advanced practice authority. So it's important to know your state of licensure scope of practice laws. Role issues include an overall decline in demand for the CNS specialty. Education is complicated because many of the certifying exams weren't based off of graduate program preparation rather than experience. Additionally, there's role clarity issues because the CNS role is unique and because it uses a foundation based on nursing practice and system organization. So clarifying this to other healthcare constituents in the healthcare landscape at large is important going forward. The future outlook of the CNS role, there are some bright spots in that there's increasing authority. From 2010, there's been an increase from 20 to 28 states that allow CNSs to practice without supervising physicians. There's been an increase from 13 to 19 states that allow independent prescribing of medications for the role. Healthcare reform, because the CNS has a hand in a lot of different projects, education, they're able to lead practice improvement and quality improvement projects that can ultimately lead to healthcare reform. And standardizing CNS programs is also very important going forward. In 2015, the AACN recommended adding simulation, but there's still a lot of variation in CNS preparation, and universal preparation is a point of emphasis. The core competencies for the CNS role are based off the 3 spheres of influence that we talked about. Competencies are based off performance, knowledge, and skill. Hamrick's 7 competencies and make up the 7 core competencies of the CNS role. Regardless of the specialty, the CNS is expected to know and apply the 7 APN competencies. Direct care, promote health, improve quality of life, utilize a holistic approach, and evidence-based practice. An example would be provide expert and specialized assessment of complex patients and utilize evidence-based practice in the treatment and care of illnesses, symptoms, and responses to illness using advanced concepts related to the nursing process. Consultation. Interaction includes that among patient, staff, or systems, and the consultant is recognized as having specialized expertise and can assist with the problem solving. Examples would be in co-managing complex patients, in referring a long-term care patient to the appropriate specialist. For example, if they have coronavirus, including pulmonology, infectious disease, etc. Systems leadership, managing change. Examples of this include developing or contributing to staff communication forums, conflict resolution among staff, and an evaluation and introduction of new technology. Collaboration. Ultimately, the goal is to improve patient outcomes and outcome processes of the healthcare system at large. Examples include discharge planning and providing and ensuring ambulatory and community follow-up of a patient. Additionally, CNS can collaborate with researchers on clinical research projects as well. Coaching, examples of this include educating nurses and interprofessional staff, providing publications on research and conference presentations, and providing bedside education. Research, interpretation, translation, and use of evidence. The last competency includes ethical decision-making, moral agency, and advocacy competency. Examples of this include being involved in the facilitation of patients moving from long-term care to palliative care, accounting for that patient and their family's values, beliefs, and cultures when making the best informed decision. Those are the 7 competencies expected of every CNS within their role, regardless of specialty. In conclusion, the CNS role, there's a variety of work settings because the role is so unique and can be a part of a number of different settings. The 3 spheres of influence drive the CNS role in direct patient care, nursing, and organizational spheres. The CNS role is largely state-specific with respect to scope and can change drastically depending on the situation. The overall emphasis within the CNS role is complex and vulnerable patient populations. The CNS role, again, is based on the 7 competencies expected of all CNSs, regardless of specialty. Overall positives for the role is that there's increasing authority. CNSs are able to do more and in more locations. Emphasis on complex and vulnerable populations within the role goes hand in hand with current healthcare trends as the population ages and continues to show longer life with more complexities and comorbid conditions. Overall negatives is that there's an overall decline in demand for the CNS role. Education is still a point of debate as there's not universal preparation. And role clarity, being able to clarify what you do and why to your healthcare constituents and the healthcare landscape at large.